Afternoon and welcome everyone. My name is Mark Clark and I'm the Technical Assistance Manager in the CUI's Division of Technical Assistance in the Technical Assistance and Research Center. Welcome to the Substance Abuse, Alcoholism, Opioid Misuse, Best Practices for UIOs webinar session. Today is part 3 of a 3-part community of learning series entitled Facing Mental Health Challenges for Urban Indians. This interactive 3-part series provides a special focus on mental health issues ranging from coping with grief and loss to chronic stress and alcohol substance misuse. We're honored to have you here today. We kindly ask that you place your name, organization, tribal affiliation, and title into this chat box below. In addition, we welcome any feedback you would like to provide about your webinar experience in our survey link. The online link is pasted in the chat box as well. Next slide, please. The National Council of Urban Indian Health is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives, AIANs, living in urban areas. The CUI is the only national representative of the 41 Title V urban Indian organizations, UIOs, under the Indian Health Services in the Indian Healthcare Improvement Act, ICHIA. The CUI strives to improve the health of the over 70% of the American Indian Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. This is today's agenda. We devoted 60 minutes, and of course, we value your time. The agenda is fairly straightforward. Again, we're going through our introductions, and in just a moment, we'll introduce our speaker. Next slide, please. A few observations about housekeeping. This webinar is being recorded, and all mics have been muted unless you're otherwise directed. Please turn your camera on to allow for interaction, as this maximizes the audience participation. Again, it's a 1-hour-long session, and your questions can be typed into the chat box. A Q&A session will be offered at the end of this session, and slides and recordings will be available at the end of this session. Available on site, and they'll be provided to all the registered participants as well. An evaluation will follow. Again, we value your feedback. Next slide, please. A few details on how to ask a question or comment. First, you need to select the chat feature at the bottom of your Zoom screen. You can do that by moving your cursor and just hovering over that feature. When you click select on your mouse, you then can type your entries into the question box that appears on the right-hand corner of your screen, and we'll all be able to see your entry there. Feel free to enter your question at any point in time during the session, and we'll look forward to addressing your comments and questions in the order in which they're submitted. Your feedback is important to us. Please don't forget to take our survey. Again, an online survey that will ask you about your reactions, your suggestions about future topics. It's really important because this information guides how we select our topics, and the information we'll provide to you. It's a valuable service for the CUI and the CUI's constituents. Next slide, please. I'd like to introduce our presenter. Pamela is the National Suicide Prevention Consultant for the Indian Health Service and headquartered in Rockville, Maryland. Pamela is responsible for the development and oversight of the Suicide Prevention and Care Program. Her work focuses on program and policy development, program implementation, and evaluation. Pamela has a master's degree in social work and currently holds advanced practice licenses in North Dakota and Minnesota. Pamela is an enrolled member of the Ogallala Lakota Sioux of the Pine Ridge Indian Reservation, Pine Ridge, South Dakota. Pamela is currently completing a doctorate in social work at the University of Pennsylvania in Philadelphia, Pennsylvania. Following the introduction, we'll have a brief knowledge check question. will pop up on your screen in just a moment. And after that knowledge check, we'll pass the baton to Pamela, and we'll begin immediately following the knowledge check. Thank you. And now, ladies and gentlemen, please welcome today's presenter, Pamela Endofhorn. Pamela?
Hi, good afternoon. Thank you for the welcome, Mark, and thank you for, as always, including in-house service with NCUI. So I'm Pamela Endofhorn, and today we're going to be talking about mental health, substance abuse, alcoholism, opioid misuse, and best practices for urban Indian organizations. Next slide, please. Disclaimer, first and foremost, just want to say my views expressed in this presentation are those of the speaker and not necessarily represent the views, policies, and positions of Indian Health Service or the U.S. Department of Health and Human Services. That means that basically blame me if you don't appreciate anything I'm saying, and feel free to talk to me about it, simply because we're going to be talking about a lot of really pertinent information in regards to mental health and substance use today. Next slide, please. So after today, what I'm hoping when you walk away today is, what are you going to take with you? Basically, the contributing factors related to substance use during the COVID-19 pandemic, looking at the impact of the COVID-19 pandemic on substance use, and then being able to generalize those impacts and determine future generations for practices within the UIOs. Next slide, please. So I'm going to frame this because a lot of times we talk about substance use, we talk about mental health, we talk about all of the impacts that we're feeling, but right now we're dealing with a very specific time in the world that's related to a global pandemic. And often we're asked at Indian Health Service, what's the impact? What are you seeing in regards to how is this impacting the opioid epidemic? How is this impacting alcohol use? How is this impacting basically everything mental health wise? So we're going to talk about that. We're going to frame what we're seeing today in the pandemic. And so what's COVID-19? Got to talk about it to make sure that everybody understands where we're talking about this from. We're talking about the virus SARS-CoV-2. And the definition is on screen, pulled this directly from the CDC. And we have to talk about this from that perspective, that this is what we are all dealing with within not only the United States, but across the world. It is a global pandemic. If you have more information needs, please go to the cdc.gov for coronavirus and look up all of the information there that is for COVID-19. Next slide, please. And so what do we know about this? What we know is that hospitalization rates are higher for American Indian Alaska Natives. We know that this data point, it's kind of limited. This is our difficulty right now, is that a lot of the data, when we talk about data, we have to be very specific in understanding that data is not real time, meaning it's not today. Usually on the national level, when we're pulling data, there can be a time lag. Depending upon the data set, which that data is being pulled from, there can be 6 to 12 weeks. And beyond that 6 to 12 week lag, there's additional lag when epidemiologists have to break down that data to provide the reports to the general public. So the data that's provided a lot of time, especially by the federal agencies, have a lag time. But what we do know is that when we're looking at specific tribal populations, specific such as Navajo and Hopi, we are seeing huge impacts by COVID on American Indians and subsequently Alaska Natives. Next slide, please. We're also seeing that the comorbidities that we have within the American and Alaska Natives is also having an impact in relation to the COVID. I'm going to say the COVID to COVID. We have higher rates of pre-existing underlying health conditions. We lack environmental public health structure. We have disproportionate impact of structural racism and socioeconomic factors and limited and poor accessibility to healthcare. What does that mean? So when I was looking at this, and we often talk about these health disparities, we often talk about how impactful this is to American and Alaska Natives. What we're seeing really comes down to how is the life that we live as American and Alaska Natives impacting when we are experiencing COVID. So those pre-existing, gives an example, heart disease, diabetes, that has an impact when we're also dealing with COVID. And then that also can have an impact when we're dealing with substance use. Those all have those pieces, but beyond that, we're a person within our environment. And so when we lack the infrastructure within our environment, we're seeing higher rates because of the lack of resources and quality care. We're also seeing the lack of empathy, understanding, and through the systemic racism and the impact of socioeconomic factors like lack of transportation, lack of infrastructure. A lot of times we talk about telehealth, and we're going to get into telehealth a little bit later, but we also have to frame it within this as a disparity, because a lot of our communities may not have adequate access, even within urbans, have adequate access to the internet. So telehealth, although it is a great mechanism, if you do not have the availability or ability to meet with a provider because you lack a cell phone, you may not have funds to buy a cell phone that has a camera, or you're on the job and you have to meet with a provider and it's difficult to find a confidential place to have that meeting, that also is a disparity. And then of course, the access to healthcare. Next slide, please. And so what is it? What are those existing underlying conditions? Talked a little bit about diabetes, talked a little bit about obesity and heart disease. All of these conditions put American Indian and Alaska Natives at a higher risk for serious illness if they contract COVID-19. This is where when we talk about how do we prevent it, we're talking about vaccinations, how do we treat it? We have adequate treatments right now, but when we think about it from the perspective of what are we seeing as impacts, we have to be aware that when our people do experience the illness that is related to COVID-19, they are 6 times more likely to be hospitalized, and they're 12 times more likely to die. COVID-19 has changed healthcare within a very short amount of time. And the impact that has had on substance abuse and mental health treatment has been staggering. Next slide, please. So let's ask a question. I love to engage with people. Please put your answer in the chat. I'd like to know what your feedback is. But what is a likely contributing factor related to a rise in substance use and overdose during the COVID-19 pandemic? Is it social isolation? Is it stress? Is it lack of support system? Is it all of the above? Feel free to add into the chat. Oh. I think the alls have it. And when we look at this, it makes sense. Next slide, please. Because what we know is that the impact of COVID-19, the global pandemic, has radically increased stress. It has stressed our coping mechanisms, and it has resulted in an increase in mental health and substance abuse. It has impacted all of the pre-existing conditions beyond just heart disease, diabetes, obesity. It has also exacerbated current situations, current mental illness, such as depression, even suicidal thoughts and ideation. A question I often get from tribes is, are we seeing an increase in suicide? Because I'm the National Suicide Prevention Consultant. Are we seeing an increase in suicide? We don't know. That lag time I talked about a few slides back, we're still in that lag time. What we've seen for the general population is that suicide rates actually has maintained. It's actually kind of dipped a little bit. But just because it has dipped for and maintained for the general population doesn't mean that it hasn't increased for specific demographics like American and Alaska Natives. So the breakdown of that data, the reporting of that data becomes even more imperative by the federal agencies that look at the data sets. And it really has to come out and has to show specific to that population the impacts. Next slide, please. But here's the downside. We aren't just looking about suicide. We're looking at the entire spectrum of mental health and substance use, because the psychological stressors of COVID-19 have been staggering. You know, you're worried about the health of your family and your loved ones. You're feeling isolated and alone. Physical distancing of 6 feet, it's hard. You're afraid of getting COVID. You're having people that you love die. Exposure. You went someplace, got exposed, or do you have it? The fear and stress that comes from that, and the stigma and discrimination of if you did get infected and then you might have affected somebody else. The impact of that. Next slide, please. So all of these stressors play a huge role. So do the social determinants of health, meaning what is going around in your environment beyond just illness, substance use, mental health. The loss of jobs, incomes, getting needed healthcare services and you can't. Example perfectly right now, where you have in certain states the impact of COVID on EDs and you are having a heart attack. That was across the Washington Post. I saw that reported, CNN. This is the reality, that you can't get needed access to healthcare services, possibly not enough food or the food that your family can eat or needs to eat, and then inability to pay for rent, pay for housing. Next slide, please. So when we're looking at this, you have to look at it more than just the mental illness, but the person and the environment. I'm a social worker. We talk a lot about person and environment. We love to talk about person and environment, because what we recognize is that the individual in of themselves is not just experiencing their physical, emotional, and spiritual reality. They're also experiencing the social impact and implications that is going around in the world around them. Because of COVID-19, because of all of those other stressors, you're seeing an increased rate for substance use and overdose. We're seeing the increase in the number of positive urine drug screens. We're seeing increase in the use of cannabis and alcohol. There's an increase in ED visits, emergency department visits, and drug-related deaths has reached an estimated 93,000 deaths in 2020, which is a 30% increase. All of this is just within the last 2 years, 2020, 2021. Next slide, please. So let me ask the question, health conditions related to substance use and it could increase in a person's risk for becoming severely ill from COVID-19. True or false? Put it in the chat, let me know. True, true, true. Okay, it looks like the trues have it. Next slide, please. Vote. There we go. It can increase it. It can increase the person's risk for becoming severely ill from COVID. What we know is that people who abuse drugs are at increased risk for becoming severely ill. We know that people who use drugs are more vulnerable by becoming infected with COVID-19, that they experience worse outcomes, And this is especially true for those with opioid use disorder. And they have a higher vulnerability related to chronic cardiovascular and respiratory conditions related to substance use. So example being individuals who smoke, be that tobacco, cannabis, other drugs, they have a worse likely outcome when infected by COVID, because it's a serious threat to those chronic lung conditions. And those who use opioids may be more susceptible to a severe infections. And the use of stimulants can increase stroke, heart attacks, all of that, which may also be connected to COVID. So when we're looking at individuals who are substance using, they can have a more severe outcome when it comes to COVID-19. Next slide, please. So what are we looking at? Specifically to treatment. It's like, okay, we have this patient, they're substance using, they're substance abusing. What can we do? Especially now during COVID-19. Unfortunately, the impact that we're seeing is that there's longer wait times. We're seeing reduction in in-person services. We're seeing an increased use in telehealth, which is great if you can access it. We're also seeing use of telehealth for medical assistance treatment like methadone, and we're seeing more reimbursement under Medicaid, Medicare for SUD services. But racial inequalities and equity still exist. People who are American Indian Alaska Native are still disproportionately affected, dying at a greater rate, suffering disproportionately from a wider range in acute chronic illnesses, and justice inequalities still persist. What we know for the impact is that it's neither just a downward decrease in services or inability, but it also has changed the face. That's the piece we have to pay attention to, is how has it changed what we're doing versus just decreasing services? Is there benefits? That's the question we need to ask. We're going to get into that a little bit later. Next slide, please. What is likely contributing factor related to a rise in alcohol consumption during a COVID-19 pandemic? You tell me in the chat. Is it stress? Is it availability? Is it boredom? Is it all of the above? It's like, come on, Pam, give us a hard question. All of the above. Next slide, please. What we know is that the evidence is limited, but what we have seen through sampling, the study that I put on to this slide has shown, next slide please, that those individuals who were part of this study, now realize it's a study, so it's a limited data set. Realize that limited data set may not be reflective across all demographics. So there's always limitations. That is a limitation. But for those individuals that did take part of this study, there was an increase. They were engaging in binge drinking, and they were engaging in extreme binge drinking. They were more likely to be impacted by COVID, and their rate for drinking has increased prior to the pandemic and now in the pandemic. So what do we have to pay attention to when we're looking at this? That people are consuming alcohol in greater amount during the pandemic. But more research is, of course, always needed. The reality is that mostly it's due what we see as stress. Now, how they're defining stress, that's the piece though, because it can be all of the above, but it can also be stress that has yet to be determined or identified. So when you're looking at this as an agency and as an organization, think about it from a stress perspective, a stress diagnosis model. What are they dealing with? And what is that? And how is that causing stress within their lives? Next slide, please. So we know that it's worsening. Alcohol use is up. We know this. We know they're using it more than what they used pre-pandemic. And we know that for this study, for this data set, that they're generalizing to the larger population, that individuals are dealing with stress related to the pandemic, right? Next slide, please. So, has the COVID-19 pandemic impacted substance abuse treatment only in a negative sense? You tell me, true or false? What did I just say earlier? Reply in the chat. True. Telehealth has been amazing. Oh, false. False. Anyone else? False. Okay, it looks like the falses have it. Next slide, please. We need to talk about this because it really comes down to how are you looking at now. Whenever I talk about studies and I present a lot of information related to statistics and data and all those fun studies, we have to really look at what's being talked about. And the Journal for American Medical Association, JAMA, had 2 specific studies that they looked at in regards to the opioid epidemic. So they're looking specifically at opiate use disorder, and they're looking at it within the pandemic. And so they really were looking at it very specifically. So let's go over those 2 because the outcomes are really interesting. Next slide, please. Why are we looking at this? Because when we look at opioid use disorder, there are very specific ways in which we can look at it from a data perspective for a population. And how do we know that people are utilizing cocaine? How are they utilizing heroin? What does this look at? One great way is urine testing, urine drug testing. And this, by measuring what those urine drug tests are doing, if there's an increase in the call for testing, we know that there's an increase of use. And so we can start looking at that. But we noticed during the pandemic that there was an increase, especially for certain drugs like fentanyl and methamphetamine, in addition to cocaine and heroin. But is it possible that that increase could be an exacerbation of the pandemic? Because it could really look at it from a different perspective, meaning that people are at higher risk for substance use are getting a urine drug screen at a higher rate than actually just using more. That's one piece we have to pay attention to. How is all of when we talked earlier, those social determinants of health, one being structural racism, how's that driving this increase? Because is it a true increase? We have to ask that question. Is it a true increase? Next slide, please. Because we have to look at it from a different perspective, because maybe it is, but maybe it's not. What we looked at, so we looked at a different one. So JAMA looked at another one, and they looked at it specifically in EDs. And they're looking at it is like, you know, maybe people are showing up more in the EDs. So when, I'm gonna just totally butcher the name, Ochelek. People butcher my last name all the time. But Ochelek et al. Looked at specific cases in Virginia. And they looked at this increase of 102 cases during the height of the pre-pandemic, and then again at the height of the pandemic from March to June in 2020. And they looked at a single emergency room. Pay attention to that. What they noted was that the proportion of overdoses that were not fatal increased while the total remained the same. What does that mean? Next slide. What that means is that even though people are still requiring emergency room treatment, they are not necessarily requiring it at a greater number. We have to be paying attention to how the data is being reported. Basically, what we are thinking is that we may not be seeing a true increase in opioid, but we're seeing an increase in how it is being gathered. That's the most important piece. So are we seeing this? Possibly. I always tell people, be careful when we look at statistics, be careful when we look at data, because I like how the last sentence of this really kind of pulled it all together, that although COVID-19 has introduced a number of key challenges to receiving treatment, all differently affecting low income and other vulnerable populations, it has been accompanied by changes favoring access to care. Next slide, please. So, are we having an increase in opioids? It's like, Pam, tell me, are we having an increase in opioids? Maybe, but the bigger piece, we are having beneficial outcomes. We're actually getting better access to care through, somebody said it earlier, Monica said it, telehealth has been amazing. But in addition to that, we're reducing financial barriers. We're easing restrictions on dispensing of MAT therapies like methadone, and we're expanding the role of telemedicine. So despite the fact that we could be, really depends on what the study is and how it breaks down, the fact is, though, is that we're actually seeing beneficial outcomes because people are able to access care in a different mechanism, which they may not have done prior. Next slide, please. So there's complications. There's increased use of methamphetamine in combination with opioids, and we're looking at disruptions in healthcare and siloed safety nets combined with social and economic stressors. So it's fueling the epidemic, the opioid epidemic. And then overall, opioid-related overdoses are possibly increasing, but we don't have really real-time national reporting databases. So we have to be careful with the data. Always be careful with the data. Always read the studies and find out what it really means and then question it. Questioning is a great concept. Next slide, please. So what do we need to pay attention to? So now this is like, okay, Pam, what does this mean? What are you talking about? We have to invest in public health infrastructure for tribes, specifically within urbans. Because remember, just because a person may have a smartphone and they can access telehealth, that does not mean that they have a place where they're safe to engage in treatment. That's a big one. I'll give you an example. I have a friend up in Philly who provides treatment. And he said sometimes, he said he'll be talking to a client, and the client will be running, they were a delivery person, they would be running between deliveries talking to him. And he said it was because that was the only time they were alone, that they felt comfortable talking to him. And so he had to make adjustments in the telehealth services he was providing to be able to meet the client where they were so that they could engage in treatment. This is the reality we have to pay attention to, because infrastructure plays a huge role in that, but also how are people utilizing that infrastructure. We need to strengthen healthcare services for American and Alaska Natives by investing in training, outreach, and recruitment. Now is a great time for training. And you're like, really? Because we can't see anybody in face to face. Yes, it is. Because a lot of the trainings that are being offered, especially for substance use disorders, are now being streamed through web services, online platforms, whereas previously you had to go fly someplace to get the training. Now a lot of organizations have switched to online virtual platforms. That's important. Now is a great time to be able to start training people, because now they can access services where before you would have to pay additional dollars to send somebody someplace. Now they can access it in their home or at work during work hours. If they're working from home, during work hours. Invest in timely access to healthcare services through innovative approaches. This is the best piece, is that with the influx of telehealth, think about how can you utilize it differently versus just face-to-face or just having them come in. How can we use what we have been given with telemedicine, telehealth? How can we use it in new ways? Next slide, please. And that's everything for me. Thank you, and we'll move into the question and answer section. Question, I'm very curious about the way telehealth will be evaluated, because telehealth has never been utilized to this extent. For this wide variety of health issues, and are patients that use telehealth getting a good health outcome as if person-to-person meeting with a doctor? That's a great question. And that's a question I know that we in health service have been thinking about as well. How do you ensure that services that are being provided are quality? How are we ensuring that they're meeting standard? And then definitely, how are we ensure we're meeting the need? Because That is one of the hardest pieces. And so when we're thinking about it from the perspective of telehealth, the question always comes up is assessment, especially when we're talking about physicians for medication and such. How can we assure that when we are seeing somebody, we're seeing them in a way that ensures that assessment is adequate, but also that we're actually seeing what we need to see to be accurate in what we have to do after, meaning providing treatment, providing medications, all of that fun stuff. So the evaluation becomes very important. I have a friend who's out on the West Coast, and for her evaluation, she's in private practice. For her evaluation, it has become very tricky because she does often survey after her meeting with the client, and then she'll do periodic random surveys to see, you know, are you getting enough care? Is there something going on that they didn't talk about or didn't feel comfortable talking about? And often what she finds is that a lot of her patients feel either rushed or feel like they couldn't talk where they were talking in order to really take advantage of the service. And so this was something that she has to take in consideration. Is this a study? No, this is anecdotal evidence. So this is something we have to think about, especially within an in-health service, because what we know for our population is that infrastructure, if they have access, can they get into telehealth? But more often than that, are they in a safe place to have that confidential conversation? A lot of times, a lot of our patients anecdotally are actually going into their cars and having their sessions in their car because it's confidential. They can move to a place where they can have better signal service and they feel like they can actually engage. So we have to think about innovative approaches. How do we look at this and how do we talk to our patients to know what their experiences is and how do we help change our practices to meet that? Great question. Christina, do you see telehealth continuing post the pandemic to meet the needs of community members? I have seen it, especially in the mental health field, be extremely successful in engaging clients that would otherwise have many issues accessing therapy in person. My hope is, yes, I am hoping that telehealth will continue and it will increase. Because when I look at it from a perspective, especially for suicide, now I'm a national suicide prevention consultant, so that's my frame. But for suicide, in the prevention of, it has greatly increased the access to care. That's the piece, that if an individual can get into a service, that's the tricky part. If they can get into service, then they can access that care easier. But we also are very much being responsive to the reality of our shifting clients. A lot of our clients are younger and they're more comfortable texting, they're more comfortable being on the phone. So this is really starting to come to where that client base is, specifically for youth, to where they are already. So my hope is, yes, what am I seeing? Are we seeing that nationally? We are. We're seeing a lot of increase in telehealth and a lot of states that are supporting expansion of telehealth to meet those needs, especially when it comes to accessing services. Monica, also, I heard the loosening of restrictions on billable telehealth is coming to an end in December. Can anyone else confirm? I have not heard that yet. I have heard rumblings is what I would call it, meaning that they've been talking about it. I suspect that we will hear clarification within that time frame. So we can come to expect something that, be that guidance from CMS or basically policy come out that says this is what we're looking at. But there are states who have taken the next step and have expanded, be that under Medicaid, Medicare in their own state or other avenues to ensure that telehealth will increase and accessibility will be maintained. So it really more to come on this one is what I always like to say, more to come. Could be increasing telebehavioral health to those not normally reached, don't want to go to a doctor, lack of local services. Is there a shift in those that like in-person care and treatment decreasing? That's a good question. What I know, what we've been seeing within IHS is that for those areas in which we do offer telehealth, there's an increase for them to want to actually utilize the telehealth. Chris Ford, who is our TBHCE director, what he reports frequently is that patients like telehealth because it assures confidentiality, it's accessible, they can make appointments on their own time, they can access the service easier, they don't have to travel long distances. The only downsides is infrastructure, if they can get cell signal, and if they can assure confidentiality on their end, meaning are they someplace that they can be safe to talk or feel safe to talk. So it really comes down to, as I like to say, it really comes down to what are we seeing on the ground, because what we're seeing on the ground in one place may not apply to another, but a lot of times there's generalities, if I can speak, if there's generalities. One of them is that American Indian Alaska Natives tend to be anecdotally seeing telehealth as an increase in access to services versus a decrease, and appear to be more comfortable. Are we gonna evaluate this? More to come. Because telehealth is so new, and so we have to look at this going forward and be able to really speak to it. Any other questions? Good questions. Thank you, everyone. Oh, Christy again. Do you think the broadband expansion funds will help with increasing? Yes. Oh my gosh, yes. Oh, especially Starlink. For those areas out west that are in large geographic isolated areas, anything that can help expand infrastructure can help expand access to care. So how we can get that access, even for individuals who are in urban areas, getting them the right equipment can increase their services. So innovative approaches, how can we increase that so that they can access telehealth? How can we increase that so they can get services? Because when we're looking at it from the perspective of, I hate to say post-pandemic because I don't know what that means, but as we go forward in time in relation to the pandemic, services are going to change. And I think that's not necessarily a bad thing. I think it's going to be some growing pains, but at the same time, I think that it's going to be able to meet needs in a way that previously we haven't thought about before. And it's going to give us the opportunity to really think it in a different way. And that really, for me, especially as a clinician, is how can I create a service that previously, they only have to come to see me face to face. The limitations surrounding all of that, how can I look at it in a new way? And how can I overcome these barriers to help meet their needs as they identify? So really speaking to healthcare equity, because healthcare equity is the patient receiving the services in the community where they receive services in a manner in which they're comfortable with. Telehealth is a doorway to that. I'm waiting for house calls to start again. Oh, I would love that. So to get healthcare out of the four walls, I admit, I have been advocating for this for probably the last 5 years, simply because we need to get into the community. Again, we need to be safe while we're doing it. Outreach is difficult, especially when we're in the northern population areas, snow, wind, rain, but how can we reach those populations in a way, again, that achieves healthcare equity, giving them the services where they are in a way that they're comfortable with and what they need. So really addressing their needs. So my hope is, that somehow we can restart community outreach and house calls again, because again, we have to think about it from a different perspective. Is that an innovation, and is telehealth kind of sort of the same way? Now they have their doctor in their pocket versus a doctor coming home. And how can we help increase that? How can we help patients access that and receive the services that they really want, need, and meets their needs? So great point. Any other questions? No? Well, thank you. I really enjoyed the questions. Some of them were very good. And with that, I will turn it over back to Nikui.
We do have one more question. You have one more question. Do you utilize a hybrid approach, traditional medicine and Western medicine integrated models, or an adapted medical model approach?
So when it comes to IHS and our telehealth, it depends. So if really comes down to the area that we're utilizing the telehealth in. So in general terms, certain tribes prefer a traditional Western medicine integrated approach. So they like to have traditional practitioners as part of the treatment. Some don't. It really comes down to what is the population's needs, how are they expressing them, and how can we meet that need? Because what we recognize is that some places may have more resources and access to be able to do an integrated model, but some may not. But that shouldn't mean that we can't help them integrate. If they have the want to integrate, we can help work with them to provide technical assistance of how can you learn from other places that are doing it to then create that for yourselves. It really comes down to the local. Is that something they want? Is that something they need? More often than not, it tends to be the medical model approach, simply because they may not see it as a benefit to themselves, or they may have issues being able to access traditional practitioners. It really comes down to the local level. I'm not sure if that really answers the question, but I know that that's what we are experiencing.
Thank you. Let me see. Checking the chat. Here's another one. Are there new up-to-date trauma-informed insights in hybrid treatment practices?
Oh, you're tugging at my heartstrings with the trauma-informed care. I love trauma-informed care. I love trauma-informed care from the perspective of when we look at trauma-informed, are we looking at it from an organizational standpoint? Are we looking at it from treatment standpoint? Are we looking at it from basically what kind of service? Is what we're looking at it. For me, when we're looking at it from an organizational approach for trauma-informed care and to help with basic practices that are being provided in services and quality of care, the sanctuary model is the one that the researcher is Dr. Sandra Bloom. Highly recommend that for, and what that does is it changes the organization to become trauma-informed care. It really keeps the organization aware of what is trauma, how does it look, and how do we respond to it? How are we empathic to it? And how do we change our services to meet it? When we're looking at it from the perspective of the client and the services that they're obtaining, it really comes down to, are we looking at it from the perspective of complex trauma, intergenerational trauma? Are we looking at it from acute trauma? Because we also have to be paying attention to that as well. Because if we have patients who maybe they went through the hurricane that hit down in Louisiana, Hurricane Ida, or they had some kind of natural disaster, that is a different trauma-informed care approach for treatment services than which one would be for if we're looking at complex trauma, specifically like individuals who may have no memory of the trauma. Perfect example would be date rape, especially drug-induced. That kind of care is very different because that one has to utilize the approach of both acute processing, but also other avenues of treatment and care that can access the implicit memory, the notion that the body remembers the trauma, although there may not be any explicit memory content, meaning that they can't remember the assault, but the body remembers the assault. So how do you access those thoughts and memories and feelings when they can't recall it? So that is more dialectical behavioral, not dialectical behavioral therapy, but more expressive arts, psychodrama. If you've never heard of psychodrama, I highly recommend you look into it. Psychodrama is a great way to start looking at those implicit memories. Narrative therapy, more artistic therapies help them to really access the implicit, combining that with the acute, like prolonged exposure, EMDR, cognitive processing therapy. So depends on which area you're coming from, but both of them, if the organization changes and they implement those trauma-informed care practices for services and treatment, you're going to have a really good outcome. Hope that answers your question.
Thank you. Sorry about that. How are UIOs addressing commercial tobacco misuse? Is cessation treatment getting shortchanged due to COVID concerns?
Oh, that's a good question. I wonder. I have not heard of anything on the tobacco cessation push that we do in IHS. I have not heard of it getting impacted by COVID, but the reality is most of our services, to certain extents, we're getting impact from COVID simply because we're dealing with, especially for mental health, you're dealing with the impact. Now we're dealing with grief and loss. We're dealing with a lot of other issues that, although they're and present in most pre-pandemic times, as we're going in now within the pandemic, we're seeing it from a new perspective. So what I would assume is that we are seeing a different type of impact from COVID on tobacco cessation. What that looks like, I would have to, if you want to send me an email, ask the question, I can ask my people here at headquarters if they're seeing anything and provide you additional information.
Thank you so much.
Thank you so much, Pam. It's been really helpful and so much information. We have time for our knowledge check. This is our post-knowledge check now, and we'll express our appreciation to Pam. You feel free to use your heart emojis, by the way, to show Pamela how much you enjoyed the presentation. I'd encourage you, those of you who with a further interest in the commercial tobacco misuse question, to reach out to Pamela Endehorn via email. That was a generous offer that she provided to follow up on that. Just one more reminder about the surveys. Thank you. We encourage you to visit our online survey to express your not only your appreciation but your observations, and again suggest any topics that you'd love to see us cover in the future. This particular effort to reach out to our audience and constituents is an ongoing effort, and we're always looking for ways to improve our quality. So thank you for your feedback. We're right at 1:55 p.m. and there's a few time left for a few more heart emojis for Pamela. Again, on behalf of the CUI, I'd love to express our gratitude and thank you for a really insightful and engaging presentation, Pamela. We always enjoy our work with the Indian Health Service. Thank you so much.
Thank you.
And on behalf of NCUI's Technical Assistance Research Center, I'd like to tell you, wish you have a good afternoon and stay safe, everyone. Goodbye now.